settings?
We are back on the vent, right?
I thought they already changed it.
They're here. Yep, the RT's in the room.
Okay, can we go ahead and...
Yeah, turn up the
Yeah.
support. Turn up the
Yeah.
support. Sounds are 75.
Yep.
What time is that then?
Turn it up all the way to 0 because we have to open this up. I never had it just sit like that. It's stuck in this outer ring.
So now that should
So
be
then we
cleared
can
by
pull
the
it
oxygenator there, so we're probably okay on that end. And there's just a little bit of air still up here.
We've been off a long time. It's after 66 or 70 patient. Do we
We'll
have,
just go ahead and go back on a bit here.
there's nothing arterial.
Let's go back on.
That should be a small enough. It's not making practice. Yeah.
Okay.
Start turning up your flows. Make sure this is good. Should be able to just start turning this. Hold on, it's giving me an error message. Okay. Did you turn it off? Let's turn it off. And it's looking at our pins are all the way to 0. Should start like this.
Still says fault level.
Yeah.
Push that. And then we're gonna look.
There we go. Some forward flow should be.
Alright. So we have to take the clamps off, the patient, back on Ecmo. Because we should be back on Ecmo now.
All right, let's stop.
Woo! 5 minutes. Seems like it's a lot of
Pretty sure everybody's gonna leave here saying they hope they never get air in their circuit.
Well, that's what they had mentioned yesterday, but, you know, on a different circuit, it's a little bit different manipulating it and getting air out, so we got really good with the storing yesterday.
Yep. So, we had to improvise in this room, so, everyone else had gone through a arterial air scenario. This was venous air again. But the reason that we did venous air again in this room is that, in the other rooms there are arterial, bubble detectors. And in this system, there is not a system that will alarm for you. And so, again, with the arterial air, venous air, it's the same principles. They were wanting to have the same kind of interactions. I do want to read for you just real quick the arterial air desired responses so you kind of hear what they were doing in the other rooms. For this room, there was really not a point to do arterial air, because what would have happened is we would have shot the arterial air in, it just would have went to the patient because there's nothing to stop it from doing that, and then it would have circled around through and come back venous side anyway. So with the arterial air sample, it says recognize that there's air in the circuit, check the arterial side of the circuit, but again, you're probably not going to entrain air on the arterial side because it's positive pressure, so you'd actually be spurting blood from the site that's broken on the arterial side. But in those scenarios, it would be as if air got past the oxygenator that was venous, and it's now coming out the arterial side. So that's what they were simulating in the other cannulas, check the stopcocks, check medications infusing into the central catheter circuit. Actually, let me just pass this on to you, because it's very similar to what you saw with the venous air for the same kind of things as the desired responses.
We did not change it very much. Yeah. All we did was venous.
And I will go through the arterial air PowerPoint so that you guys can kind of see what that also looks like. Maybe I will. Tom, you want to just read through the rest? I stopped at the arterial air. We just read through the rest of the objectives there. I don't want to fight with my computer quickly.
So for the arterial air, you're going to recognize that the pump's off because it should be alarming. It should alarm. You need to look at the front or the display to figure out why it's alarming and what stopped the pump. Recognize that it was the arterial bubble detector alarm. Clamp the patient off Ecmo because you have air on the arterial side of the circuit. Do a complete circuit check. Check the oxygenator. Check all connections on the arterial side. Check for air at arterial side clamp. Check venous side. So if you clamp the patient off Ecmo and you de-air the circuit, you have to be really careful that a bubble didn't go up that arterial line and is sitting right below your clamp. So the last thing you do is get ready to put the patient back on, take that arterial clamp off, and lo and behold, the last thing you do is give the patient an air bubble. You just prevented them from getting meningococcal. Check the venous side to make sure that the air hasn't entrained through the venous side and across the membrane and is going up the arterial side. So you're going to attempt to determine the cause of the arterial air. Aware that arterial air on BB Ecmo is dangerous if there's any type of right to left intracardiac shunt. Communicate in requesting emergency vent settings, call for help, and then the stop point is take patient off Ecmo to remove air that's significant.
And so this they just wanted to have us go through again for your adult patients, having air going back into that arterial return. The ones that you're most worried about would be that intracardiac shunt. A few microbubbles going into the right atrium. Lungs will likely filter out those microbubbles. And actually, I've heard Dr. Bartlett say up to 60 cc's. He's not worried. Seems like a lot of air to me, but I trust Dr. Bartlett. So I've often quoted that that's what he's passed on. But if you didn't know and your patient has an ASD, you're going to have some trouble with injecting 60 cc's of air into that right heart, because then it will be going to the left heart and all over the place. So just being cognizant of those things. Microbubbles probably not going to be a big problem in that respect. And that's what they wanted me to focus on too, is that through those intracardiac shunts, you're worried about stroke. You're worried about coronary circulation due to that air getting in that right atrium. And then 200 cc's of air in the adult right atrium at once will lock the forward flow of blood. So that's where I think, again, Dr. Bartlett said 60 cc's of air, probably okay. 60 cc's of air in there is quite a bit. I didn't inject a full 60 cc's in there, but it's a pretty big chunk of air. And so, just as you guys are doing, is you try to get all the big segments out as much as you can, and using the technique where you're giving volume and you're also pulling out what you can. And then when you have those few microbubbles left, send it forward to the oxygenator. Have someone still watching the arterial side to make sure